Good evening, everyone. So actually this presentation which I'm going to share is intended for the delegates of IORACon, where I had presented it in yesterday. So for next 20 minutes, we'll discuss about clinical pharmacology reconciliation in ensuring patient safety for chronic pain management. So we are going to discuss about some issues on clinical pharmacological reconciliation and how it can ensure patient safety when the patients are suffering from chronic pain. So this will be our discussion agenda. First of all, we will discuss about what is clinical pharmacological reconciliation. Then we'll discuss about how to ensure patient safety. Here, there is a disclaimer. Because of this talk was actually sponsored talk for a part of one pharmaceutical industry yesterday. This was kept as a part that how PEA, we'll discuss what is PEA, the role of PEA in chronic pain management. And in between, we will also analyze some case studies related to this topic. So first of all, as this presentation is meant for those practitioners who are always there to allay our acute pain. So when we suffer from acute pain, we went to them and they help us to get rid of acute pain. They are the orthopedic doctors. So yes, this pain is unpleasant sensory and emotional experience. And what we are going to discuss, that is the clinical pharmacological aspects. I try to make it like that so that it will not be much painful to those who actually allay our pain, because for next maybe 20 minutes, they need to dissect through these different drugs and how the drug actions happened like that. But what I want to emphasize from this slide, actually pain is something which alert us that something dangerous stimuli that happen to our system. So this is very important to alert ourselves. So this presentation make us alert regarding some important aspects, and it protect us, it protect our patients, just like pain. As we are talking about chronic pain, we are not going to discuss about it in acute pain management, but I just bring this concept of acute pain because the alertness. We need to be alert when we should be very focused while prescribing, and that is why we need to understand this clinical pharmacology reconciliation. We should be very alert like these persons, CRPF Jawans, who are always there to protect our life. Just like that, the clinical pharmacological review, reconciliation, and feedback, this is generally meant for improving quality of patient care. So this also protect our patients by ensuring safety. So there is no doubt in that that prescribing in any form is a critical skill. And to acknowledge that critical skill, if we perform this CPRRF, that means clinical pharmacological review, reconciliation, and feedback, that could help us. And what are the different parts of CPRRF? Number one, if there is no indication for a current drug, we need to assess, then we need to deprescribe that. Whether there is too much or too little a dose, then we need to correct it, which is very important while we are managing our patients who are suffering from chronic pain. Then there could be indication for a drug, but it is not prescribed. So it is our duty to add it. There could be a necessary but wrong choice of a drug or regimen, or unnecessary and redundant drugs in the prescription. So we have to deprescribe that. Apart from that, we need to look for adverse drug reactions, including drug allergy, drug interaction, or incompatibility. Whether some adverse drug reactions is overlapping or not, we need to assess. And finally, we need to balance between benefits and risk of each prescription to ensure the rational therapeutics. For that, we need to have a prompt review of a freshly prescribed drugs or regimes, consider different patient-related factors for treatment individualization, pharmacokinetic, pharmacodynamic rationale. Access is very important with affordability and availability. Adverse impact on quality of life by the drugs, if happening or not, we need to assess. Apart from that, for long-term care, which is very important, that is monitoring drug therapy, whether there is some safety issues appearing or not. Medication errors generally happen during the transition of care from ICU bed to general ward or HDU, or from general ward to discharge. So this needs to be taken care of. And as we will discuss some cases, this is an 86-year lady suffering from hypertension, COPD, complaining low back pain. Now, for low back pain, she was prescribed with gabapentin 400 milligram along with nortriptyline 10 milligram. On top of that, who was the prescriber of gabapentin and nortriptyline don't know that the lady was already taking pregabalin nortriptyline, and the patient and patient caregiver not inform the prescriber. So unfortunately, patient who is the prescriber don't know that the patient is already taking pregabalin and nortriptyline. So this is very important when we are prescribing. Sometimes the patient will not tell, but we need to ask again and again. And it is also the duty of a patient or caregiver of that particular patient to tell the doctor whatever the drugs patient is taking. So this is very important. Now the patient is taking again a pregabalin and nortriptyline. On top of that, patient is taking aceclofenac and paracetamol combination. Also deflazacort was given, pantoprazole 40 milligram once daily. We can see the ongoing medications for her COPD management and hypertension management and hypothyroidism management. Now what happened? The patient was suffering from severe GERD with symptoms along with dryness of mouth. And now the patient visited another physician and he was prescribed a fixed dose combination of pantoprazole plus itopride. On top of that, the patient was taking some ondansetron 8 milligram thrice daily as an OTC medicine, because we all know in our country over-the-counter drugs are very popular. And on top of that, again, her daughter who felt better with domperidone tablets when she was suffering from vomiting, she tell her mother to take domperidone 10 milligram thrice daily. Now, when she also have some cough, the patient was prescribed with azithromycin. And what happened after 3 to 4 days? The patient presented to the hospital with 3 episodes of fainting, dizziness, and sudden tachycardia of heart rate of at around 140 to 180, like that. And the QTC was found to be in ECG, it was 560. So it was a clear-cut case of QTC prolongation, and it could be ended up with torsades de pointis, which is a fatal condition. So what happened to her? This is called as prescribing cascade. Why this is prescribing cascade? Because as the patient is taking almost 20 milligram of nortriptyline, and we all know nortriptyline has a very high anticholinergic burden score. So this only could be responsible for that severe GERD. Apart from that, the patient is also taking a steroid deflazacort along with aceclofenac paracetamol combination. So aceclofenac is there. So there is a high chance of development of GERD. And we can see here the dryness of mouth too. So that is a part of anticholinergic syndrome. So patient has anticholinergic syndrome. Now, when she visited to another physician, so she was prescribed with some drugs without identifying the cause of the disease. The cause of the disease, this GERD and dryness of mouth, is due to some drugs. So drug-induced disorder is a very important differential. So we need to acknowledge, and here it was missed. On top of that, some other drugs was prescribed. And what happened? That leads to some, we all know these drugs has a potential to produce QTC prolongation, and QTC prolongation happened. So this is, we need to address the prescribing cascade. That means I am taking one drug, that drug is causing some atrocity, and for that atrocity, without stopping that particular drug, I am taking another drug to control those symptoms. And what happened? As I am taking another new drug, that will cause another new symptoms, another atrocities. So ultimately, the cascade will go on and on unless we stop that drug which is primarily responsible for the adverse reaction. And this is known to be prescribing cascade. And how we can prevent prescribing cascade? We should have a plan of rational deprescribing. This was our paper which was published in JAPI in 2021 regarding deprescribing, how deprescribing could improve patient outcomes in chronic long-term care. And that is what today we are discussing, how the clinical pharmacological review, reconciliation, and feedback can help our patient to prevent different types of medication-related disorders. So medications, when we are prescribing, we need to play safe. And that is why specifically when we are treating our elderly population, we should follow this mantra, that is start low, go slow, but go. So diagnosing drug-induced disease is a neglected differential diagnosis. and that we all should acknowledge. And this is a quote from this year, Harrison 2022. They had clearly mentioned drug-induced death is the second most common cause of death there in USA after the motor vehicle accident. So we need to prevent this type of accident. And that is why we need to treat adverse drug reactions, and we need to prevent their recurrence. We need to avoid prescribing cascade. Specific emphasis should be given for those patients who are renal or hepatic compromised, pregnant, pediatric, or elderly patients. This is another case, a 71-year male presented with pain in bilateral knee joint, now advised paracetamol 1 gram twice daily for 10 days. This particular patient presented with a drug-induced liver injury. Now, if we just check, this is a pharmacokinetic guidance by which we can understand what should be the ideal dose of paracetamol or any drug in aged population. We all know the pharmacokinetic property will change with aging, how our system behave with drug, that will definitely changes with our ages, and this is why we need to acknowledge that. So in this formula, we can see how the volume of distribution and elimination rate constant, the change in that can influence the maintenance dose of a drug. So in a healthy adult, non-elderly adult, if the dose is 1000 milligram, then what should be the dose to attain the same efficacy of paracetamol in elderly subject? We can found by this formula, it should be at around 750 milligram. So this is why, this is an example by which our clinical pharmacological review, reconciliation, and feedback concept using pharmacokinetic parameters and pharmacokinetic changes that may happen in elderly could help our geriatric population to attain the same result with safer dose. So as we are talking about patient safety, so we all follow this mantra given by Hippocrates, Primum Non Nocere, that means above all, do no harm. And it was a data from America that 36 million Americans use over-the-counter pain medications daily. As today we are talking about chronic pain management. So OTC pain medications in America, the prevalence is so high, and unregulated system in our country, we can assume how much the burden of OTC pain medications in India today. And in this particular study, they had found the paracetamol, aspirin, ibuprofen, ketoprofen, and naproxen were the most commonly over-the-counter pain medications used by the Americans. Now, if we just take one very safe over-the-counter drug, paracetamol, and check its safety. Yes, it is a safe drug, but there are instances, there are different cases where paracetamol also can cause liver injury. And that is the thing, the NAPQI. Paracetamol converts to NAPQI, and this NAPQI is potentially toxic to our liver. And actually, glutathione helps to eliminate this toxic metabolite of paracetamol. But when there is absence of glutathione or deficiency of glutathione, like in case of alcoholic, AIDS patient or poorly malnourished patient, then there will be less elimination of NAPQI, which could increase the chance of paracetamol-related hepatotoxicity. Now, if we consider some drugs like carbamazepine, barbiturates, phenytoin, isoniazid, or rifampicin, they are CYP2E1 and CYP1A2 inducer. And therefore, there will be more production of NAPQI. Also, the tobacco can induce these enzymes. So the tobacco intaker, the smoker, the jorda eater, they will have more exposure to particularly this NAPQI, which could increase their chance of getting paracetamol-induced hepatotoxicity. So we only saying over-the-counter paracetamol is safe is not at all good. So we need to acknowledge these factors. Apart from that, when we are talking about NSAIDs, there are some risk factors. Like if the patient has multiple comorbidities, patient is on different anticoagulants or steroids, just like in our first case, elderly patient, history of peptic ulcer disease or GI bleed, or the patient having smoking history or alcoholic history, they are the high risk population to have NSAID related toxicities like nephrotoxicity or GI bleed. So we need to aware or address these areas. Another important issue is detailed medication history. So the temporal relationship is very important. So if a patient tell us that I have Stevens-Johnson syndrome, the serious skin reaction with one specific drug, we need to take a thorough medication history to understand whether that particular drug is responsible for SGS or not. Generally, what happened, there is a window period of 1 to 3 weeks for SGS, and for DRES, it could be a 2 to 6 weeks duration. So sometimes it is very difficult to remember those offending agents. The patient cannot tell us the proper medication history. So we should be very aware on that. Otherwise, eliciting detailed medication history give us a clear picture regarding whether this drug has a chance or high causality to cause this type of reactions. And we can then prevent by predicting unpredictable episodes. This type of atrocities we can prevent. And there are some drugs we often used in chronic pain, specific chronic pains like carbamazepine. We all know it could also produce Stevens-Johnson syndrome or TEN. By checking whether the patient having this allele HLA-B1502, we can understand. If it is not, then we can safely give carbamazepine. Otherwise, it is better to check for HLA-B1502 allele before prescribing carbamazepine. Now, when we are talking about pharmacological treatment of chronic pain, there was a beautiful paper which had emphasized the need for change. So first of all, we need to understand the difference between nociceptive pain, whether it is a nociceptive pain or a neuropathic pain. And another important issue is the pain treatment driven mainly by tradition and personal experience. So it is, we need to be very much evidence-based while we are prescribing drugs for pain management. And another important issue, it was found that the poor patients and physicians' communication is also responsible specifically the patient could need to understand what is actually the goal is, what, and physicians also need to know regarding the patient's perspective of pain. The side effects and limited individualized therapy also a barrier for successful management of chronic pain. Difficulty in maintaining the balance between adequate pain relief and acceptable tolerability. That also is a challenge. We can see here physicians' perception of treatment success. Here ITT means individual treatment target. So patients missing their ITT, now you can see in this group almost 20% of the patients, they feel they actually missing their treatment target. But when we are coming about the physician's perception, it is almost, we can see here, the 70% of the physicians think that they have attained more than satisfactory level in managing pain treatment. Again, those patients reaching their individual treatment target, there also a very good number of patients, almost more than at around 15%, where the patient's perception and physician's perception is not actually matching. And now if we just check why the patient stop treatment, discontinue treatment, the major reason is adverse event. So lack of efficacy is one cause, but majorly due to the adverse events related to the therapy bound patients to stop treatment. And what happened? There is a possibility of establishment of a vicious cycle that alternates between suboptimal efficacy and treatment emergent adverse effects, which lead to discontinue from the treatment, which prompt for treatment discontinuation. And this is a beautiful diagram you can see from that particular paper by Varasi et al. What we had discussed, the need for change in pharmacological treatment of chronic pain. So what happened there? So if we are advising treatment, there could be three possibilities. Number one, there could be adequate analgesia, which we want. Next is there could be a chance of side effects or insufficient analgesia. Both insufficient analgesia and the insufficient analgesia due to maybe various reasons, but ultimately may lead to increase the dose of the drug. And if we are increasing the dose of the drug, there could be a possibility of more adverse effects. So there could be a number of population who will struggle with those adverse effects, but they will stay with the treatment, but a portion of them will drop out. And whatever that may be, ultimately that will lead to low quality of life. And when there is side effects, that could be a reason of low tolerability or some interactions or due to results of some polypharmacy. What happened? We need to reduce the dose. And when there is reduction in the dose, that is again associated with either insufficient efficacy, but when there is insufficient efficacy, there is a possibility of acceptable tolerability. So when there is insufficient efficacy, despite having a good tolerability level, we need to increase the dose. So when we increase the dose, that will cause again unacceptable tolerability. So there will be more side effect. So there will be a sufficient efficacy, but unacceptable tolerability. So again, dose reduction need to be done. So this vicious cycle will go on and on. Similar thing may happen when there is adequate analgesia, specifically when we are giving analgesia with opioids. So it is a third line agents when we are talking about chronic pain management. There are specific area where we should use only those opioid drugs. Otherwise, they are very much restricted. So when there is adequate analgesia, but still sufficient treatment going on, that's okay. Then we can continue that adequate analgesia with using those particular drugs. But when there is tolerance development and that leads to insufficient analgesia, so ultimately that vicious cycle of dose increase need to be done, and dose increase to dose reduction due to unacceptable tolerability, that is going on, and ultimately the whole issue leads to low quality of life. Now coming to third part of this discussion, that role of one molecule. This is generally a pharmaceutical that or we can say that this is specifically a nutraceutical, that is PEA. And when we are talking about PEA, we need to understand a few important points, specifically the role of our autocoid system in generation of pain we need to know. So there is a bidirectional communication between microglia, mast cell, and astrocytes, which reinforce the deleterious signals that acting on the neuron, and which ultimately via mast cell degranulate or transgranulate in the brain parenchyma and release different inflammatory cytokines or mast cell mediators, and also neurotrophic factors. That neurotrophic factors is actually helps in healing. Same thing happens when there is astrocyte or microglia mediated reactions or activations. There will be proliferation and phenotypic transformation with abnormal release of these inflammatory cytokines and also neurotrophic factors. So what happened by targeting this area, this zone, there were some animal model using carrageenan and prostaglandin induced hyperalgesia, the formalin test for persistent pain model, or even the visceral hyperalgesia produced by instillation of nerve growth factor into bladder and sciatic nerve ligature model of animals. That is specifically a model for neuropathic pain management. So it was found the beneficial role of PEA. But in case of acute pain model, like acute thermal pain response, that was not affected by PEA. So how this PEA or palmitoylethanolamide acts? There is one proposed mechanism. It has an effect on mast cell and specifically CB2 type of cannabinoid receptors, ATP sensitive potassium channels, TRP channels, and nuclear factor kappa B. It also acts on the PPAR alpha, the nuclear receptors. It has an action on an orphan receptor, an agonist with GPR 119 that specifically involved in GLP-1 secretion. It also, as we are talking about cannabinoid receptor, it was found that it acts as a competing substrate for the endocannabinoid homologue, anandamide. What is that anandamide? That arachidonylethanol-amine. So by this mechanism, palmitoylethanolamide acts. So actually, palmitoylethanolamide is nothing foreign to our system. It is an endogenous chemical. So when this is produced when we are in a stressful condition like peripheral tissue inflammation, neuroinflammation, or having pain. Now this palmitoylethanolamide, by entering into the cell, they will react to that PLD, and if we check that palmitoylethanolamide, there is two receptors in the inner surface known as FAAH and NAAA that metabolize this palmitoylethanolamide into that palmitic acid and ethanolamine, which results in those actions of anti-inflammation, neuroprotection, and ultimately pain relief. So there are an ample number of animal studies conducted with PEA, which had shown its anti-inflammatory, anti-nociceptive, or anti-neuropathic, even some neuroprotective role. In a rodent model, it was shown that it reduces the spinal inflammation or tissue injury, ameliorating the recovery of motor limb function. It limits the mast cell infiltration and activation, reduce that activation of microglia and astrocytes. We had discussed the mechanisms by which microglia, astrocyte, and mast cells are responsible for chronic pain. Reduces tissue edema. It has also an anti-epileptic action, anti-allodinic or anti-hyperalgesic effect, improves neurobehavioral functions, and in animal models, it was shown that protection against MPTP-induced neurotoxicity. We all know that MPTP models are very familiar model, or it helps us to understand the drug's role in neuropathic pain. So in this study, it was found the arm which received PEA, there was statistically significant decrease in the TFAP beta-actin ratio, therefore suggesting the beneficial anti-neuropathic role of PEA. And as we are talking about PPAR alpha, which is a lipid activated nuclear receptor, this binds with that, and these mechanisms actually helps in reduction of pain and reduction in inflammation. If we now dissect some clinical evidences with PEA, in a double-blind, placebo-controlled, multicentric, randomized control trial, including more than 600 patients of low back pain, mainly the lumbosciatica, 1 or 2 tablets of PEA of 300 milligram was taken. What happened? There was a significantly better results in favor of 600 milligram and 300 milligram tablets, and 600 milligram tablets, they had a better result compared to 300 milligrams. Similar type of observation, it was found by a prospective observational study with more than 600 patients who are suffering from different etiologies, chronic pain. Here, the 1200 milligrams daily for 3 weeks, followed by 600 milligram daily for 4 weeks. This was the dose schedule, and PEA was associated with significant decrease in pain intensity in all patients. And regarding the safety, it was well tolerated, though the studies which are in the public domain, we found that more than 60 days study was not there. So we can conclude like that less than 60 days PEA appeared to be well tolerated. Now another meta-analysis with the PEA in the treatment of chronic pain, where we can see the etiology, mainly the more than 80% patients who were included in this meta-analysis were suffering from degenerative disorders, but it was found the pain intensity was statistically significantly reduced at 60 days compared to the placebo arm or control arm. And if we just check what are the important factors which could suggest the successful PEA therapy, first of all, in this meta-analysis, what they had found, the treated group statistically significantly better in reduction of pain. And surprisingly but true that double-blind RCTs showed better results in favor of PEA compared to open label studies, which is very important, because when we are talking about blinding and we are checking some subjective parameters, not objective parameters, subjective parameters, because pain is something which is very much subjective. Blinding is a very important design, and double-blind studies are in favor of this molecule, means this has some signs. Another important factor that is very important to note is age less than 65 years. So if age is less than 65 years, they are more chance to be benefited by this molecule. But males or females, etiology degenerative versus etiology neuropathic versus etiology mixed, there was no differences. So independent of these factors, PEA appeared to be effective. Now coming to another part which is combined with PEA in this particular molecule we are talking today, that is astaxanthin, which we can call it as a king of antioxidant, because it has a reactive oxygen species scavenging capacity of more than 6,000 times that of vitamin C, 800 times that of coenzyme Q10, 200 times that of polyphenols, 150 times that of anthocyanins, and 75 times that of alpha-lipoic acid. It is actually a direct antioxidant. It activates also the different enzymes which is antioxidant. And very importantly, we all know very recently concluded or published study of vitamin C in COVID patient. In high dose vitamin C, it was found that vitamin C acts as an pro-oxidant. So initially, which was thought to be beneficial in COVID, it was found that high dose vitamin C, that is in the intravenous vitamin C was used in that particular RCT. It was found it acts as an pro-oxidant, and generally the arm which received vitamin C IV intravenously, they had higher mortality. Now, vitamin C and vitamin E and carotenoids, they are antioxidants, but they, just like what we had mentioned now, they can become pro-oxidants under certain conditions, like in case of vitamin C in high dose or in presence of decreased renal function, it could be acts as an pro-oxidant. It has, this astaxanthin has a mild, very mild COX-2 inhibition, and it specifically inhibits the inducible nitric oxide synthase enzyme. This is very important because this iNOS enzyme is responsible for inflammatory nitric oxides. We generally know that nitric oxide, when it is produced in our vessels, is beneficial, but endothelial nitric oxide synthase enzyme is not inhibited by this astaxanthin, but this iNOS enzyme is inhibited, and therefore the reduction in the production of nitric oxide, and it also suppress different inflammatory gene expressed by nuclear factor kappa B, and also decrease prostaglandin E2, interleukin 1 beta, TNF alpha. And we can see how it quenches the singlet oxygen. Singlet oxygen is responsible for this oxidant activity, and it scavenges the free radicals to prevent or terminate the chain reactions. So that is why they are direct antioxidant, and we can see the relative singlet oxygen quenching activity of astaxanthin compared to other molecules like alpha lipoic acid, vitamin C, coenzyme Q10, green tea. So it has a very high activity. Generally, it is recommended or approved dose, which is varied in different countries, but ranges between 2 to 24 milligram, up to 24 milligram. So in this picture, we can see how astaxanthin acts in our molecular level, how it also helps in mitochondria mediated reactions. By these mechanisms, these complex mechanisms, we can understand the role of astaxanthin in inhibition of oxidative stress, and its anti-inflammatory activity is well appreciated. Now, to the final part of our presentation, there is one case study of Mr. A.G., who is a 42-year diabetic hypertensive patient suffering from chronic neuropathic pain, especially prominent at both feet. The NRS score was 7. Now, if we just check the medication history, we found that the patient was on gabapentin 300 thrice daily with duloxetine 60 OD. Topical cream was prescribed. Pregabalin and nortriptyline was prescribed again, along with venlafaxine 75 milligram. Patient presented to the hospital in a confused, agitated state with some auditory hallucination. He had tremor, increased sweating, fever and diarrhea for last 1 day. Clinically, it was seen, or after examination, it was found there was myoclonus, tremor, hyperreflexia, and also the blood pressure was elevated. So it was preliminary thought to be an infective origin, but when we found the detailed medication history, the case was diagnosed immediately as serotonin syndrome. There were duloxetine, nortriptyline, venlafaxine the patient was taking, and all these are serotonergic agent. So as there was serotonergic agent ingestion history and along with spontaneous clonus, we can conclude it as a serotonin syndrome, and we had started the treatment of serotonin syndrome, which is very much conservative. But this flowchart is very important for as an toxidrome approach when we are suspecting a case of serotonin syndrome. By using this flowchart, we can diagnose serotonin syndrome easily. So when we are talking about the chronic pain management in this particular patient, at the time of discharge, we need to plan for that CPRRF, that means clinical pharmacological review, reconciliation, and feedback for this patient. The initial thing is that the patient has very poor glycemic control, so we need to control that. And insulin initiation was there, which actually needed for the glycemic control. Gabapentin 300 milligram thrice daily was prescribed, along with that molecule, which is available in India in the name of PNOC XL, that is Palmitoylethanolamide 400 milligram with astaxanthin 1 milligram, twice daily is the dose, was prescribed, with duloxetine 30 milligram once daily. And what is very important to give emphasis on stress management and yoga, because for pain, these all aspects are very important. Not only drug is important, we need to ensure the other modalities of pain management, and the role of stress management and yoga is well appreciated in different parts of the world. And after 60 days, the NRS score was 3. So what is very important, the same patient who was on multiple drugs like venlafaxine, nortriptyline, duloxetine, and gabapentin, the same time the patient not get the optimum efficacy, but there were some atrocities, like the patient need to be hospitalized due to development of a drug-induced disorder, serotonin syndrome. But by doing simple things like glycemic control, using minimum drugs like gabapentin, duloxetine, along with one molecule nutraceutical, PA astaxanthin combination, giving more emphasis on stress management and yoga, the patient's pain score was markedly reduced. We cannot say like that this molecule, that PA and astaxanthin, help that particular patient to achieve the optimum pain score. But what we can say, it could be possible as an additive effect of PEF astaxanthin combination. Together, we need to give emphasis the other parts of pain management like glycemic control and stress management and yoga. So with that, what is very important? What should be our take-home message? First of all, the personalized interventions are very important, even when we are talking about chronic pain management. And one drug does not fit all. Just like one dose does not fit all, we all should acknowledge one drug does not fit all. And that need to be individualized. We always should balance between risk versus benefit of any therapy. That should be pain management. When we are talking about chronic pain management, it is a team game. It is not a game by only one prescriber or one physician. It is a team approach. We should have a qualified orthopedic pain management specialist, stress management specialist. Then we also need to give emphasis whether there is some medicinal issues, some other comorbidities need to be taken care of. Just like in our case, the diabetes was there. We need to take care of diabetes. And also we need to acknowledge the drug-induced disorders and how the drug-induced disorders can be a potential cause in triggering different atrocities. And there are definite research gaps in chronic pain management. we need to address those gaps, and there are different adaptive designs that we can use when we are doing this type of studies, like withdrawal design. Withdrawal design is very important when we are dealing with some disease where outcome is basically subjective in nature, and that the first line what we had mentioned, that one drug does not fit all. So if we can check in the running period this is working, so at that point of time, if we just divide it in two groups and we can follow up the results of these drugs in a properly designed randomized control trial, then we will understand the actual benefit and actual adverse effects of that particular medicines. So with that, I thank you all for listening this. Again, I am telling this talk was intended to delegates who were attending the International Congress on Rheumatology and Orthopedic. But as the presentation is for all physicians who are managing chronic pain in day-to-day life, I think this could be helpful for all those physicians who are managing chronic pain in their daily life. Again, I wish you all and thank you for listening. If you have any question, you can put it in the chat box, in the comment section, so that we can address those. And the most important disclaimer is this presentation is not for lay people, non-doctors. So anything in this presentation should not be used by any of those who are not doctors for their own treatment. You should visit your doctors who will treat your chronic pain. Thank you. Thank you very much.